Before I introduce the next speakers, I just wanted to take this time to recognize the conference logistical planner for this conference, and that's Connie Sage. Please help me, join me in thanking her for all of her behind-the-scenes work on this conference. Really, she's the one we need to be thanking. Great. So we're to our physicians panel, and it's my honor to introduce the facilitator of this panel. State Auditor John Morrison has agreed to facilitate our physicians panel, and I just wanted to share a few things that I know about this character. I've had the opportunity to work with State Auditor Morrison over the past 7 years in Montana. He and his office has been instrumental in helping us pass several statewide tobacco initiatives, the last being the tobacco tax initiative, which set aside new money for some new health programs, one of which provides more access to health insurance. And he's going to talk just a little bit about that. The other thing that you should know about State Auditor Morrison is that he was one of the attorneys that helped us secure the master settlement agreement with the major tobacco industry so that we could then have funds available in the state to help pay for past costs of tobacco disease and current and future. So please join me in welcoming John Morrison.
Thank you, Kristen, and thank you all for inviting me to be a part of this important conference. I am John Morrison. I'm the Montana State Auditor. I am the only auditor in America who audits absolutely no one, which some people say is good work if you can get it. But what I do spend time doing is regulating the insurance and securities industries. The insurance side of that has given me occasion to work on the many and complex issues involving access to affordable health care for Montanans. And so, as Kristen said, this is an issue that interested me when I was in the law practice, and we spent quite a number of years working on the tobacco case. I met Kristen then and Bob Moon then as we were involved in that work, and really since I hit the ground as a public official in 2001, we have worked hand in hand on issues that we both care about, and I know that some of those issues are very relevant to what you're talking about today. I want to thank Kristen and the planning committee that have put so much effort into making this conference a reality. It came about, as you know, as a result of a joint resolution from the 2005 legislature. I come to you fresh from the front lines of the battle of the 2007 legislature. I'm covering up a few bullet holes, but I will tell you that I have tried to stay clear of the crossfire as much as possible, but I have been able to contrast what's been happening in the last several months in Helena with what happened in 2005, and it's a sharp contrast. Many, many great things got done in the 2005 legislative session, and the resolution that gave rise to this symposium is just one of them. One of the other things that came out of the 2005 session was some major steps forward in the issues that I mentioned before about affordable health coverage. We enacted the Insure Montana program, and we significantly expanded the CHIP program, which were both made possible by I-149, the tobacco tax initiative that significantly raised the tobacco tax. That was done not because the tobacco tax was a good way to tax unpopular minority, but rather because there is significant cost shifting that is not addressed in the insurance market. And by raising the tax on tobacco and making people more accountable for the cost of that lifestyle when they pay for it at the counter, it not only creates a deterrence to smoking, particularly among children, but it also helps to reverse the cost shifting and pay for health coverage in such a way as to make it more affordable and accessible to more people. We now have almost 10,000 small business employees, most of them in the $20,000 to $30,000 a year range, covered under Insure Montana, and we have another 3,000 kids on CHIP. So as a result of those steps in the 2005 legislature, and by the way, Insure Montana, I think once we get our Medicaid waiver accomplished, we'll be up closer to 15. So those changes in the instituted by the 2005 legislature will soon be adding nearly 20,000 Montanans, mostly lower income Montanans, to the insured rolls. That's a good thing. That's the kind of thing that a legislature that works together across party lines with the interests of the people of Montana and the health care concerns of the people of Montana first can accomplish. Kristen suggested that I mention that, and I'm always happy to give that sermon and say that I hope you will join me over the next couple of years as we look at a way through the 2008 ballot initiative process to expand health coverage even farther. We have a panel of illustrious experts with us today who are going to comment from their own perspective on issues that you've come here to find out more about. And the objectives of this panel in particular are these. We want to learn from these experts and on the basis of not only their expertise but also their geographic diversity about their current practice in pain management, including types of patients and settings, barriers, policy and otherwise, that they encounter to good pain management. And I understand there was a presentation yesterday that mentioned insurance barriers, which I'm particularly interested in. Successes in overcoming challenges and effectively managing pain at a local level. Number 4, what resources are available for their community, including other practices and integrative medicine. And number 5, what would improve pain care in each of these experts' communities. We will hear from Dr. Catherine Borganick, who is a geriatrician and internist practicing in Bozeman. She's the medical director of the Bozeman Deaconess Hospice and Palliative Care and has been active with the Pain Task Force since its inception. She's currently chairing her hospital's pain committee. We'll also hear from Dr. Patrick Danaher, who's a graduate of the Kirksville College in Osteopathic Medicine, completed a residency in clinical anesthesia at the Naval Medical Center in San Diego, and a pain management fellowship at Harvard Medical School. Dr. Danaher was director of pain management for the Pain Management Clinic at the Naval Medical Center in San Diego before joining Missoula Anesthesiology in 2004. We will hear from Dr. Michael Schabacher, who is a physiatrist and the medical director of the Northern Rockies Regional Pain Center in Billings. He received his MD from the University of Washington, completed his residency with the University of Virginia. We will hear first from Dr. Randall Sechrist, who is the medical director of the Montana Spine and Pain Center. He's board certified in orthopedic surgery and has practiced in Montana since 1987. Dr. Sechrist has clinical and research interests in the management of chronic musculoskeletal pain and the incorporation of integrative healthcare modalities in the treatment of chronic pain states. He's a faculty affiliate with the University of Montana School of Pharmacy and a member of the advisory board for the Montana Neuroscience Institute Foundation. Dr. Secrease received his MD degree from Duke and completed an orthopedic residency at the University of Virginia in 1987. He served as a general medical officer with the Indian Health Service from 81 to 83 in Browning, which we're particularly grateful for your doing, an area of great need. Let me also just mention that we have several other physicians in the audience who we invite to participate actively in this discussion. Steve Martini from Kalispell. Dr. Martini, are you here? Okay. Steve and I have known each other for a long time. Pam Roberts, also from Kalispell. Dr. Pam Roberts. Janice Gomersall from Lolo, Dr. Gomersall. And we also have family nurse practitioner LaDonna Ladd from Great Falls. So we invite you to pipe in whenever you feel like it. And Dr. Secrease, would you like to begin?
Sure. Does this work? Yeah, good. Okay. When Kristen asked us to put together a panel, the real goal, I think, that she had sort of wanted to see happen was get a feel for what's going on across the state in terms of pain management. So I'll start by sort of giving a brief idea of what's going on in the western part of the state and especially here at St. Pat's. We've been, well, there's been a pain program here at St. Pat's for probably 20 years. The first 14 years, it was primarily a behavioral medicine-based program, which really was an inpatient program where patients came and spent time, usually 3 weeks, and stayed in a hotel, and it was a very intensive program that really focused on physical therapy, occupational therapy, relaxation techniques, the behavioral aspects of chronic pain. Over the last 4 years, I think that we've seen a shift in terms of what we're trying to accomplish here at St. Pat's. One major shift that I think is occurring is that we're viewing chronic pain now as a public health issue. It's simply not a practice of pain management. It's a public health issue, and I think that St. Pat's has looked into the future and realized that the role that we need to play in this region is changing as well. So what we're seeing happen and what we're driving at this point is really looking at the region and what we can offer not only from patient care, but also how we can put systems in place that actually improve the public health in western Montana. So one of the shifts that I see occurring and I see embraced with St. Pat's is moving back to that model of interdisciplinary or multidisciplinary care and really taking a true team approach of trying to improve the health of a population and trying to create resources not only that can be used here at St. Pat's, but resources that can be extended into the community so that St. Pat's becomes a resource for practitioners, not only for referrals, but also for education, for outreach activities, and for research activities. So I would say there's always a focus of patient care. You have to provide expertise. But one of the things that I've discovered over the last 4 years of trying to work to put a true multidisciplinary team of providers together is that, quite frankly, pain care boils down to about 90% coordination of care and about 10% expertise. Now, you've got to have the expertise, but without coordination, this is a complex problem that the patients get lost. So what we've really tried to put together is systems and processes which can be used not only within our own institution, but extended into the periphery so that these patients come into a system, it's coordinated, and these patients get good care, and at the same time, because of all the things you've heard this morning and last night, we try to minimize the complications of managing chronic pain. And it's not complication-free. This is a profession that is fraught with potential pitfalls if you don't have the coordination in place. So no matter how much expertise you have, those complications can arise, and the less coordination you have in your efforts, the more likely those complications are to occur. And that includes, the issues we've discussed with opiates. That includes diversion, that includes addiction, that includes aberrant behavior, that includes death. All of those things occur not because the expertise is not there, but because the coordination of the efforts are not there. The other two things that we've really tried to push are this concept that good health care, especially public health, is not affected by simply providing patient care. The biggest things that have been done across history to affect the health of a population had nothing to do with what one provider did to another person. They had everything to do with huge changes in systems like sanitation, like water, those sorts of things. What we can do as individual practitioner pales in comparison to what you can do when you put systems in place that affect problems on a widespread basis. So those are the principles that drive what's happening here. Now, part of that process comes down to also looking at a responsibility not only to patient care, but also to taking a serious look at the responsibility for organizations such as St. Pat's to create this system of education and system of clinical research to really look at our patient populations and to extend that information out to the periphery. So when we start looking at clinical research in our role with the Montana Neuroscience Institute Foundation, we're looking at trying to get best practices and best information and extend that out to the periphery. I think we're going to continue to see that, and I think that we're going to continue to try to drive that. Couple of other comments, I think, in terms of potential barriers to healthcare. One of the things that I would like to see happen is we tend to have gotten into this place where we've equated treatment of chronic pain with an opioid issue. The treatment of chronic pain is far more than simply solving the opioid issue. Chronic pain is not simply prescribing of opioids. So I think one of the things we need to understand is we need to readdress that and not let the discussion come down to whether you prescribe opioids and what opioid we prescribe. We also have tended to equate chronic pain care with doing things to people. So the procedures, all of the technical aspects of medicine. That has led to a situation where we have really, we've really gotten ourselves into a situation where we've abandoned some of the behavioral aspects that have worked well for years and years and years. And the trend is that there's no economic incentive to provide those services. There's no economic incentive to provide the coordination services. And when you get into this situation, you're going to get more and more prescribing, more and more procedures, and less of the hard work that it takes to actually manage chronic pain. Chronic pain management is a long-term investment. And the only way to do this is to create systems that can manage it in the long term. So those are the issues that I see in our area that need to be addressed. We need to really look at ways to stimulate some discussion that goes beyond the discussion of abuse, opioids, and procedures. We need to go back to our basics of how do we manage the public health of this population of patients, and how do we reduce the complications, and how do we give them the best pain care that we can. So in a nutshell, that's what's going on, I think, in western Montana and Missoula anyway. Thank you.
Thank you, Dr. Seacreast, and let me just clarify that the way this is going to go is we will hear from each of the panelists for up to 15 minutes, and then I'll have some questions for them, and then the audience can ask questions, and then we'll wrap up at the end after about 40 minutes of questions or so. So there should be plenty of time for questions, and it says Dr. Danaher had to run to the hospital to attend to a patient.
Oh my God, not that.
If it sounded like my microphone wasn't working, it wasn't. Dr. Danaher had to run to the hospital to attend to a patient. He will do his best to get back, so we will not hear from him next. Dr. Schabacher, would you like to?
Would like to start out by just saying I appreciate everyone's involvement in this meeting. I think it will do much to help us throughout the state to understand what's going on elsewhere, and maybe we can work together to provide more comprehensive and more effective pain management services. I'd also like to make sure and acknowledge those folks that came to Missoula, Dr. Dahl and others. I very much appreciate having the opportunity to hear what they have to say. I work at St. Vincent's Healthcare. I'm an employee of the hospital in Billings. The pain clinic that I work with started in 1999 with John Oakley, who's a neurosurgeon, of worldwide recognized expert in pain management, left Seattle to experience life in Billings, and worked with a group of neurosurgeons. When I first came there in 2003, the practice was then sold to St. Vincent's Healthcare, and on April 17th, 2006, we suffered a loss that is completely beyond comprehension when Dr. Oakley's plane went down in the mountains of Utah. So with his death, then I ended up being the frontline person for the practice, and we have done our best to carry on his philosophy and his goals, of which he had many. His focus was on education, and I think that as I talk today, the recurring theme is going to be on education, not only of other providers, but of patients and others. Dr. Oakley had as his one of his goals expansion of services beyond the Billings area, and with a focus on outreach clinics. And we had actually been invited to visit a variety of cities in northern Wyoming and Montana in order to provide those outreach clinics. Right now, we don't have the resources to do that. We have considered the use of telemedicine in order to try to expand our services. Our practice, because Dr. Oakley was a neurosurgeon and he had a real focus and a passion for implantable devices, we have a large number of drug administration pumps and spinal cord stimulators as part of our practice. Our practice currently has two physicians, myself and a family practitioner. On full time, we have a neurosurgeon who is helping us with our implantable devices, and we have anesthesiologists that comes on a weekly basis for injections. We have a psychologist who works part-time with us, and a chemical dependency counselor. The hospital, before Dr. Oakley's death, had committed to building us a new pain center, and it's completed. It's a huge facility, and most of it's unused currently, and we're hoping that with time we can recruit the resources, that being manpower, in order to staff this clinic. The need is huge. Our patient population is primarily middle-aged and older folks. We do see almost no pediatrics at all. We have very few Native Americans in our clinic, despite the fact that their representation in our area is quite large. There are some real access issues there. And that was an area that we had hoped to expand, but currently we're not really able to do that. We are not doing a lot in order to try to advance our practice in terms of trying to solicit more referrals, simply because we have too many patients and not enough time and not enough practitioners to see them all. Our catchment for our practice extends through northern Wyoming. We get a lot of people from Cody, Sheridan, and even Gillette, to the east, all the way to the North Dakota border, and then across the High Line. Absolutely astounded to see how far people will travel to come to our clinic. And I think that speaks, at least in part, to the fact that their practitioners really don't feel comfortable managing their pain. So one of the goals that we had early on was to try to develop relationships with providers in outlying communities so that we could provide a consultative service primarily, and make recommendations for treatment and have that treatment carried out in their home communities. And we'd be happy to see these the patients once or twice a year. Today, we really haven't been able to kind of foster that, but that ultimately was the goal. And one of John Oakley's friends was Roland Gallagher, who has spent quite a bit of time trying to organize that type of a pain center. Ultimately, we'll try to refocus our efforts on that. With regard to barriers to provision of pain management services, I think that one of the big barriers I have is the attitude of other practitioners in the community about what's involved with pain management. I distinctly sense a lack of appreciation of what it's like to live in chronic pain. I've seen, and as I'm sure you all have seen, occasionally a practitioner will suffer some type of an injury that leaves them with chronic pain, and their attitude changes dramatically over a relatively short period of time. I've seen that happen in family members as well, and I think of several women whose husbands are just absolutely unhappy with their wife, because they're in pain and they're not as functional as they could be, and their pain affects the way that they live their lives. And then all of a sudden, I remember one of them fell off a trailer, and I felt very bad for him, and he fractured his femur. But their marriage got better because of it, because he finally understood what it was like to live in pain. And I think that that's what's lacking in the practitioners. And if you sit down and listen to the people, what they tell you about what their life is like, and try to put yourself in their position, recognizing that they go to bed with pain, they get up with pain, it affects the way they sleep and function, that it's a huge impact. And so one of the barriers I see is the lack of appreciation of the impact of pain on the people that I try to serve. I experienced a significant amount of resistance from funding sources for some of the more sophisticated or costly interventions, for example, drug administration pumps and spinal cord stimulators. With the work comp system, the recommendation of one of those devices is an automatic IME someplace, and I have them, at least one company that tends to send people out of state to get opinions with regard to implantable devices, and I'll talk a little bit more about that in a bit. There's a problem in our community that's proven to be a barrier, is a lack of consistency in the way that pain management services are provided. There were a couple of what I would consider outliers in terms of their pain management practice. They tended to prescribe absolutely huge amounts of opioids in ways that didn't make any sense to me. One of them was closed down one day by the DEA with absolutely no provision whatsoever for what was to happen to all of these people that were on high-dose opioids. And I can tell you that they were lined up outside my window. They were wanting to pay double just to get in to see me. I was absolutely amazed to see what a dramatic impact that had on the community. Then these people end up in my practice, and I'm expected to prescribe medications in ways that didn't make me feel very comfortable. The impact that this had on the emergency department was tremendous as well. There was another physician that just recently left practice, and I don't know why, but had prescribing practices that were significantly different from my own. Unfortunately, neither of these physicians had admitting privileges at the hospital, so it wasn't uncommon for their patients to end up in the emergency department and then end up being admitted by the hospitalist, and that really created some real problems because the hospitalists felt less comfortable than I did with the way that these patients were being managed, and it just tends to, they tend to generalize these problems to everybody in the community. So I've had to kind of suffer with that some in terms of trying to foster a favorable impression in the community about pain management services when I have people in the community who, at least I don't agree with the way that they manage patients, and then everyone in the community believes that I manage them as well. I also have difficulty with, and I think I've alluded to this, but the attitude that other practitioners in the community have towards opioid prescription. And there's a few surgeons in town who I refer patients to who, when I get their referral back, or their consult note back, and what it starts out with is, unfortunately, they're addicted to narcotics, and I referred them to them, and it doesn't help me to have that kind of information put in the medical record. The other barrier that, at least in Billings, that we have to good care, well, I shouldn't say good care, but to providing care is a lack of people who are willing to provide pain management services. We're trying to recruit people. It's hard to find practitioners who want to sit down and do the hard work of pain management, and that's listening to what they have to say and trying to understand how this impacts their life and what you might do to help them. The multidisciplinary nature of good pain practice is difficult to put together, and I've had the opportunity to talk to Dr. Sechrist a couple of weeks ago, and I was astounded to see or to hear how he has put together, really an outstanding group of people, and has figured out a way to get it all paid for. The other
Pocket, right?
the other issue is that I have some difficulty with finding services for treating people with addiction and chemical dependency issues. I certainly would, these people need to have pain management care. It's just significantly more complicated and dependent on others to assist me with that, and I don't always have ready access to those services. Another barrier, and I already alluded to this, is this tendency by certain organizations to want to modify the way that I practice pain management, and I'm happy to take criticism. I'm happy to take suggestions, but I have a certain number of my patients sent off. As I said before, one organization in particular likes to send people to another state, but there are physicians around that will render opinions about my practice who I don't believe actually manage patients with chronic pain, and who tell me only what I shouldn't do rather than what I should do, and I would like to have suggestions about how to better manage these patients rather than to say there's nothing wrong with them. It's all in their head, don't do anything at all, and then people run with this, and I end up spending a certain amount of my time trying to refute that, and I have to advocate for my patients, and so I have kind of grown a little weary of that, and I expect that there are some who have had the opportunity to read some of my letters that probably understand the passion that I have, at least in making sure that there's some justice. And that's what I feel sometimes fails with these IMEs, is that there's no accountability with regard to the recommendations that are made sometimes. Some of the successes that I feel like we've had, I think we were on track to have some huge successes before Dr. Oakley got killed. That was a major setback, and I wasn't really prepared. None of us would have been. There's no way you could be prepared for something like that. To go at this without him, at least I anticipated working with him for at least 5 more years. And we've hung in there. So I consider it a success with his loss that our clinic is still up and running. We are, if number of patients served and referrals are any indication of how we're viewed, I think we're very successful in terms of being respected in the community as a viable referral source. We have our detractors, no doubt. I've done what I could to foster good relationships with the work comp carriers, and I think perhaps, I don't know, I was told the other day that perhaps 60% of my practice, not of the pain clinic, but of my practice relates to workers' compensation or injured workers. And despite the comments I've made about the IMEs and so forth, I have done what I can to maintain good relationships through communication and education of the work comp carriers, and they've been responsive to me, and I appreciate that. I've done what I can to foster good relationships with our referral sources. I've done what I can when asked to educate around the Billings area. If I'm asked to talk, I am happy to do so, although I have to say public speaking is not necessarily one of the things that I do, that I consider myself to do well. But anyway, I certainly don't turn any opportunities down. If people are interested, I'm more than happy to talk to them. We've been successful at securing the resources like the psychologists and the chemical dependency counselor who'd like to have more access to them and more of their time. With regard to resources within the community that are helpful, we have a very well-rounded medical community, so we have a large number of specialists that can help us. We have well-developed rehab services, including aquatics therapy and physical and occupational therapy. I have a neurosurgeon that I work with who's willing to implant drug administration pumps and spinal cord stimulators, which I have felt is one of the factors that helps set us apart from perhaps what some other folks in the community are able to provide. And I fortunately work for a hospital that, by all indications, is very supportive of our pain clinic. I have concerns because, with the loss of a neurosurgeon who was very productive, who is really going to carry this clinic, you've really been very well. I think that it's a policy of administration to make you feel like you're never really quite satisfying them, and so when we look at the numbers, they never look quite as good as what they want them to look like. So I feel a little anxious that sometimes we're not generating enough revenue, but they tell us that they're happy with what we're doing. So that's what I have to say.
Thank you, Dr. Schumacher. Our next panelist is Dr. Borganek, who, as I said, is a geriatrician, internist, and medical director of Bozeman Deaconess Hospice and Palliative Care Center. And please take it away.
I'll do my best. I'm one of those sloppy and careless physicians. We have things a little different in Bozeman. Unfortunately, we don't have access to an interdisciplinary persistent pain clinic. I'm going to start using persistent pain. It's a much better term. But what we do have are some other services that I think are really quite remarkable and excellent. They tend to focus more on acute pain and on hospital pain, which is consistently still a huge issue, and I suspect it's still a huge issue in both of your hospitals in terms of how practitioners view patients in the hospital and how they deal with their acute pain. So the two things that we do is we have palliative care consultants, which is an interdisciplinary group of people, myself, a clinical nurse specialist, a social worker, and a spiritual counselor who will see patients in the hospital, in the cancer center, and sometimes I'll do consults in my office. And most of these people are patients who have chronic diseases that either require some kind of pain management or some kind of symptom management, or addressing issues around goals of care, around their spiritual needs. Some of these may be cancer patients, but not all of them. And as a matter of fact, I think our statistics show that a large proportion of them are just people with chronic disease. A lot of these people have a pain component. Many of these people we deal with by using either by using good pain management. And I am truly convinced that many of the pain issues that we face in our community as a public health problem, if we could do better at doing good pain prescribing, we would probably solve many of these problems. So that's something that we've done, and our palliative care program actually has been extraordinarily successful. We did actually start by going to the CAPC seminars. CAPC stands for the Center for the Advancement of Palliative Care, and they do a brilliant job of taking you step by step of how to develop a palliative care program. And then we've had a couple of very serendipitous kinds of things that have been very helpful to us, including the fact that Bozeman Deaconess also runs the hospice in Bozeman, and so we were able to coordinate some of what we do with the hospice. And we see a lot of people in the hospital who have pain issues. I think we're seeing about 18 to 20 patients a month, which for a 50-bed hospital is really quite remarkable. We're also integrated with the cancer center, so I go to the cancer center meetings once a week and go to their tumor boards all the time and spend a lot of time talking with the cancer docs about their cancer pain. I was a little astounded, and this is one of our weaknesses, which is me making assumptions. I was a little astounded last week when I was talking with one of our cancer docs who are really quite excellent, but I felt like I had to take them through Pain Management 101. And I was a little surprised by that, although I don't think I should be. But that's one of the big issues, is the knowledge base of the physicians and practitioners around us. We also are looking at, through our palliative program, working with the emergency room, not just around patients that come in who might be at the end of their lives and having to best help them with what's going on there, but also with issues around pain. The ER, one of the things I've been thinking about as we've been talking about this is the whole issue of chronic persistent pain gets a lot of press, and it gets very frustrating for the physicians in the ER. I met with the head of the ER the other day, and I said, so how many people are we talking about here that you're really having trouble with? Well, there are about 5 people. But they keep coming back to the ER, and the ER gets frustrated because they're taking a large amount of opioids, and they get nervous about giving them a large amount of opioids, and they really did not understand any of the pieces there. So we're working with the ER from a system standpoint to look at those patients who come in with chronic persistent pain, and so that's going to be exciting. The other thing that we've got at Bozeman Deaconess is I chair the pain committee, and we have a couple members from our committee here. It's an interdisciplinary committee that's looking at the issue of pain. Well, when I first got to Bozeman Deaconess, this was 2002, I chaired a pain committee then, and that sort of went away after we got a nursing policy going, and then nothing really changed. And then the hospital said, well, we're going to get JCAHO certified, which I think is great. So now we have and also one of the orthopedic surgeons said, I really don't like what we're doing in terms of post-op pain. What do you think? Could you help me? And he said, I've come up with an order set, and I'd like to, do this, and blah, blah. And anyway, so that's how we got started. And this orthopedist hasn't really been involved in the committee, but we're going to drag him in because we're going to do a pilot study on his patients. He just doesn't know it yet. Anyway, so one of the things that we're looking at, and I appreciate stuff that we've gotten actually from both from Missoula in terms of their pain services and protocols that they've had is developing some really good protocols around pain, both for nursing and for physicians and for pharmacy and for us as a pain team to institute. Now, protocols are only as good as the people who use them, so hopefully we have good people who will be doing that. We're going to be doing some education both out in the community and for our healthcare providers and developing and having competencies for all of our nurses. Of course, I was just telling June Dahl, I've spoken to the physicians since I've been there probably at least once a year about pain management, and then I still have to go back to square one with these guys. So I'm working on maybe bringing June in so that they can get an older, wiser person, or at least wiser, not necessarily older, but at least wiser person talking to them instead of the same old sloppy and careless physician. One of the things I'm very excited about is after years of trying to get Demerol off the formulary, we're at least going to start restricting Demerol. I started back in the 1996 trying to get Demerol off the formulary at the VA, and I think it may be off the formulary now, but I don't know. And then the other issue, which one of the biggest side effects that we see in the hospital and in the nursing home, we're also working with the nursing homes just on the side to get some end-of-life and pain management systems going there. But one of the biggest issues that we run into in terms of pain management is constipation. And this is now going to be part of our pain management set, is not only do you order pain management drugs, but you also order laxatives at the same time. It's a basic principle of pain management, but I can't tell you, and I suspect it's not just Bozeman Deaconess where this issue comes up, but constipation in the acute hospital or any person on pain medicines, this is a major problem and can be just as painful as the pain itself. So that's sort of my big push now, is getting the nurses not just to mark off that, yes, they haven't, both in the hospital and the nursing homes, right, they haven't had a bowel movement, they just keep checking it off, but they never bother to go back and say, oh, it's been 5 days, and they're ready for discharge, and, so we're actively on the pain committee working on that. The other thing that we're looking at Bozeman Deaconess is really developing an integrative medicine service. So we have a number of practitioners in the community. Bozeman has a wealth of people who do integrative medicine, and we just have one of our physicians who is, she just had a baby, but she also is completing a fellowship with Andrew Weil down in, he's in New Mexico, I think. Andrew Weil is Arizona, a big integrative medicine doc, and any of you who watch Steve Coburn might have seen him on, what's his name? Colbert, might have seen him on there recently. Anyway, but we're going to be developing an integrative medicine program, which I think is really, really key in terms of any kind of pain that people have. So that's sort of where we are. What we don't have access to is a good integrative, both invasive pain management, both a comprehensive approach to pain management, or an addictionologist, which would be great, a good psychologist who really knows how to deal with a lot of the psychological issues that go along with people who have chronic pain. I forget what the statistics are, maybe June or Robert knows this, in terms of how many people with chronic pain also have depression. So that's a huge issue in terms of how we're dealing with things. I think some of the problems and barriers that we have is, as I mentioned before, what I assume people know. I assume a much larger knowledge base than people really have, and part of that is because I've been working in pain management and palliative care for a long time, and so I just assume that people know about this stuff, and they really don't. And it's not really their fault. I think that certainly when I was in medical school and when I did my residency, there was nothing about pain management, nothing about end-of-life care, and I really had to seek it out after I was done with that. I think it's better now, but what I'm dealing with is a group of physicians who graduated probably when I did, who really did not have any training in it, and it's not sexy. So that's one of the issues. I think bias is a big issue. We've talked about that. Lack of interdisciplinary coordination. Access. I recently had a patient and this speaks to insurance, there were two issues. One was this was a 80-year-old male who'd had multiple back surgeries, and his spine basically looked like a train wreck. And he'd had a recent fall and now was having pain going down his leg, and was on, I forget whether he was on OxyContin or whatever, but he really was in significant pain, and I was trying to manipulate his meds, and I did send him to one of our physiatrists who's going to be working with him. But one of my thoughts was, let's just get him on a morphine pump so that I can see what his pain needs really are, and then I can back him off and put him on oral. And they were all in favor of it, and everybody. Medicare only pays for a pump, a morphine pump, on a patient if they have a cancer diagnosis. So in order to do this, he was going to have to pay $100 a day, because that's what it costs. And so I could not do that. So, unless I put him in the hospital. Now there's a cost saving, put him in the hospital, put him on a pump, and, that'll make sense. And then the other, I think I alluded to the other issue, which is formulary restrictions. I alluded to this yesterday, where I have patients, there are a couple of Medicare Part D programs that really restrict your use of opioids. Some of them don't carry methadone, some of them don't carry morphine elixir, and this is really a major problem. I think the other issue is what patients can afford. We do have a fair number, given the size of the state, we have a fair number of uninsured in this state, and getting them access to alternative, integrative medicine care is really difficult. Getting them psychological care can be difficult. We have a great group in Bozeman that does physical therapy, craniosacral massage, acupuncture, and some nutritional counseling. Wonderful group, but they can only see people for a short amount of time based on the Medicare guidelines. Then they can send them to the hospital physical therapist, who, because it's affiliated with the hospital, they can provide more physical therapy, but they don't necessarily have the other integrative skills that this person might need. So it's great that they can continue with physical therapy, but they have to change and not necessarily get the kind of things that they want. So I think everybody else has sort of said the same, barriers and resources and all that stuff. I still, every day when I have a patient with chronic pain, have to educate them. I don't think anybody's really talked about them, but the huge need to educate consumers about pain, and that if you take a pain medicine, you are not going to get addicted to it. And that I spend lots and lots of time talking to families and patients about that, and I think that still is a large barrier in this state. So.
Thank you, Doctor. Dr. Danaher is still attending to his patient, and Dr. Steve Martini has generously agreed to join us up here and take Dr. Danaher's spot. Steve, you want to come on up? And Dr. Martini received his MD at the State University of New York, and has been in private practice of pain management in Kalispell for 20 years. He's a member of the American Pain Society, the International Spine Injection Society, the American Academy of Pain Management. I met him during the 1990s when I represented some people who had physical injuries and dealt with chronic pain, and found him always to be very enlightening and a great advocate for patients as well. Steve?
Well, thank you. Everyone can hear me? I can hear me, so I guess you can. Well, I appreciate the opportunity to say a few words. I wish Dr. Danaher had left me his speech, but I don't see it here.
We've got a crib sheet over there.
And I've heard some good things from the conference already. I think that, I was musing last night over the questions that Dr. Secreast posed, and had to really grapple with my own struggle with a lot of those questions concerning the treatment of pain, and I was thinking of all the labels and the degrees and the certificates and all those things that are not really who we are as practitioners, but what it is that's essential about pain management. And for me, I sort of fell into the discipline by default 20 years ago, and I was working in at that time in Kalispell in the mid-1980s in a clinic that was well ahead of its time. It had neurosurgeons and physical therapists and occupational therapists and a psychologist and a trained pain specialist from UCLA and whatnot. I don't know what the heck it was doing in Kalispell at that time. I just sort of motored into town, and there it was, and I was fortunate enough to get a job there, but for reasons beyond my control, I woke up one morning and that was all gone. But what wasn't gone was a whole bevy of pain patients that really had no direction, and so that was my very inauspicious beginning in pain management. And so I have a debt of gratitude to all of those hundreds and hundreds of patients, maybe there's thousands now, over 20 years. They've really taught me most of what I know about pain management. I've had a friendship with Randy Secrease for some time, and we've talked over pain management the last few years and how to direct the care in our locations and what the best options are. And I appreciate the opportunity to hear from Mike, I think, and Catherine about what's going on in their locations. It's a huge nut to tackle for sure. I want to give Mike due accolades for continuing to maintain the quality of care under the circumstances. I considered John a friend and learned a lot from the gentleman, and can only imagine the loss in your community. And I've had the opportunity to watch what Randy's done here in Missoula as we've tried to coalesce our efforts in Kalispell. Where we're at presently, and I want to introduce Pam Ertman, who came in late. Pam's a physician working in our clinic in Kalispell, and our hospital in Kalispell, perhaps about a year and a half or so ago, maybe now, time goes so fast, but has dedicated major resources to putting together comprehensive pain management, and we've been very fortunate in that respect. And in addition to having Dr. Ertman join us with her expertise in fibromyalgia. Oh, Dr. Roberts, my apologies. Dr. Roberts joined us with her expertise in fibromyalgia. We've recently acquired Dick Wise in addiction medicine. So I think consistent with what some of the other panelists have been saying, and certainly the experience of others, it's trying to draw from an interdisciplinary team that hopefully will give us the best outcomes. Our biggest obstacle, I think, in Kalispell has been the behavioral piece. And probably about, I'm going to say 5 years or so ago, my hospital approached me with the idea of putting together a comprehensive pain program. And we had issues then with how the neurosurgeons might participate. We did not have an interventionalist at that time. Since then, Steve Johnson, an interventional specialist, has joined us. He's been there about a year. But at that time, there were significant players that were missing. Most notable, though, was the behavioral piece. And one of the things that I said to the hospital at that time was that until we were able to marshal the services of behavioral medicine, acknowledging the tremendous impact of chronic pain in the lives of our patients, I felt like we were really going to be swimming upstream. That's been our particular difficulty in Kalispell. We have neurosurgery services and interventional services. We have Dr. Roberts for our fibromyalgia patients, Dick Wise, addiction medicine, and clinicians like myself and our physician extenders to see patients. But we've been hampered by behavioral medicine. I've been on leave for a couple of months, but I understand that we've been able to interview some people, and we hope that that significant barrier is overcome in the not too distant future. To kind of echo some of the comments that I've heard already in terms of barriers, I think that as physicians and myself, I've been privileged to be able to work with pain patients and direct my continuing education in the field of pain management, but our colleagues are not always, don't have that luxury. They're busy getting their continuing education in their subspecialties and so on, and may not have a whole lot of direct access to further education in pain management. And as Catherine pointed out, we get little to none if you're unfortunate to be as old as I am in terms of our primary training in medical school. So I think that's a huge barrier in our area. The clinicians in Kalispell, I think, have widely varying ideas about what pain management is about, I'm sure. And many times when you hear from the most vocal, you have to consider that you might be hearing the extreme, and just what filter you apply to what you hear determines what you take away from that, I think. But having said that, I think that in Kalispell, our clinicians that refer to the pain clinic many times would like to see us solve the pain problems that they have in their respective practices, which is to, and I've been, I think I've been quoted on more than one occasion as saying that, pain clinics take care of pain patients, they don't manufacture them. So many times, and the clinicians here, if you're like me, if I'm seeing a patient and I make a specialty referral, let's say to rheumatology, and perhaps this is a patient on a 4 or 5 drug regimen, which includes a benzodiazepine and a class 2 opiate and a neuropathic agent and the like, and the patient shows up in the rheumatologist's office, and frequently I think the assumption is made that the pain clinician has created that problem, when the reality more than likely is that patient came into the clinic 7 years ago on a drug regimen that was dramatically inadequate and more fearsome than what they're currently on. So there's, moreover, that patient has probably been to every physical therapist, occupational therapist, acupuncturist, naturopath, and so on. And so a lot of things, I think, fall by the wayside in the eyes of our colleagues. So I think education of our colleagues is going to be of major importance as time goes on, so that they have a better understanding of what we do. Let's see, I'm trying to think if there's any, that was the main topic that stuck out. I think most of the panelists have covered the other issues.
All right, thank you, Dr. Martini. All very interesting presentations, and I'll start by focusing on a few issues that occurred to me in the discussion, and then we'll invite audience members to participate. Not on and not in my hand. I'll start by addressing some issues that occurred to me in the discussion, and then invite other folks to pipe in. It seems to me that one of the common themes is the emphasis on the interdisciplinary team approach, and that gives rise, I think, to a number of questions. It seems like there's some issues about what the team looks like, about practice standards, and about whether there is agreement among providers on how that team works, and whether the providers that need to be involved in the team are involved and willing and able. And so I'd like to drill down a little deeper on that. Let me just first ask if any of you could address what a chronic pain interdisciplinary team looks like. Who's on the team, and do the communities that you're in, Kalispell, Billings, Bozeman, and Missoula, have those necessary team members woven into a team situation right now?
Randy, why don't you answer that first, and then
Is my mic on? Okay. Yeah, I gather that. I don't know what a team looks like. I mean, I think it looks like a lot of different things. I think that what Catherine was talking about was the integrative model, where there's a whole nother set of folks involved in the pain care, which may include non-allopathic providers. I think at a minimum, the one piece that I see constantly that folks feel like they're missing is the behavioral or the psychological piece. And whether that's provided by a psychologist, or whether that's provided by a neuropsychiatrist, or someone with that sort of training who's actually involved and engaged in pain practice or pain issues, I think that's the biggest piece that most people seem to want to add after they have the traditional clinical provider, I mean, for whatever discipline that comes from. Some folks use physiatry, some folks use anesthesia, sometimes you see internists or family medicine docs that are interested in it, but typically it's physiatry and anesthesia that have sort of staked out chronic pain management as the clinical specialty. I think that most programs clearly have to have the involvement of PT and OT. Our feeling is that chronic pain is untreatable unless there's some strategy for physical therapy, movement, get people functional. So movement is such a huge piece of any sort of chronic pain management that you've got to integrate those systems. And I don't think it's adequate to simply send a patient out to the physical therapist du jour, and send them out without a regimen. I think that physical therapists each have their own view of the world. They deal with problems differently. If you've got a sports medicine patient, then that person's going to take the sports medicine model. If you send a chronic pain patient to a physical therapist who is used to dealing with sports injuries, you're going to make that person worse, and they're going to come back and they're not going to be doing well. So it is a subspecialty amongst those physical therapists. I think that ideally, clearly what you would like to have would be a clinician, a psychologist of some ilk, physical therapy, OT. I think that we have the benefit of having also a PharmD who is it's far beyond anything that most of the clinicians understand in terms of pharmacology. So when we begin dealing with opiates and adjuvants and that sort of stuff, we have the ability to have a professor of pharmacology right there helping us. So that's a huge benefit that as I talk to people around the country, that's sort of, when they find out we have those resources, they're sort of taken aback. Those are the core pieces, and then I think that anything you can layer on around that is just continues to increase the utility. So that's the makeup of the team, I think, more than anything else. How do you get them to work together? I mean, that is a critical issue. I think that we have the luxury of having most of those physicians as St. Pat's employees, which makes it much difficult. When you're trying to put those folks together as private practitioners, much of the work that's done in the coordination of this care is not really payable in a fee-for-service basis. So you see a lot of this activity that occurs that they can't bill for the way their office is set up. So I think a lot of them are reluctant to participate in that area. So it turns out that what happens is that you have a small core team that sends out for referrals, and then that slows the process down, because then you're dealing with letters back and forth and that sort of stuff. That's not necessarily ideal, but in a lot of situations, that's what you're left with. So I guess that answers from my perspective.
Dr. Schaumacher, how about in Billings? Are the pieces of a good team in place, and is there agreement on what that team approach looks like?
Well, the pieces are available to be put in place, and they were in place at some time in the past. And our team consisted of the psychologist, of neurosurgeon, and myself, of physical and occupational therapy, and we had an acupuncturist with us at the time. She was a physiatrist who was trained in acupuncture. Now, and I hate to present this sense that we've kind of gone back words a bit. Because we lost our focus with John Oakley's death, and we kind of had to group, we are working on trying to reestablish that concept, and it really is the fundamental basis of physiatry, is this team approach, and meetings. We meet a lot, and that's really what helps, I think, us to have have some success that we wouldn't have under other circumstances, by visiting with the different people that have contact with these patients and comparing notes. So the team isn't there right now. We're approaching it before, and that's our focus in the future once we solve some of our other problems.
Dr. Borgenig?
Yeah. We don't have a chronic pain team. We have an acute pain team, and I think a team is sort of what defined a little bit by meetings and a little bit by interest, and how much people are willing to work together. And so certainly in palliative care, the team can be almost anything. I mean, there are many, many different models. I think it's a little bit different when you're talking about chronic persistent pain, because there really are some key people, like an addictionologist, like a good psychologist, like somebody who can really bring in the whole behavioral piece. And then in some ways, no offense to the interventionalists, but they're sort of a little bit in the periphery, because they do their thing, and that's great, and it does give relief, but without having all the other pieces in place, it it doesn't work. And while we have a couple of interventionalists that are in our setting, they are not part of a team at this point, and that's been difficult to get together.
That's a great point, and you know, I would hope that most interventionalists wouldn't take offense at what you just said. I mean, the reality of it is that a very small percent of our chronic pain patients require intervention, an interventional procedure, and I would submit that if you have a clinic and 90% of your patients are getting a procedure, you have a boutique. And not really a pain practice across the board. And so the real issue is, what about the 90% of patients that don't require a procedure of sorts? And it gets back to my earlier comment, and in particular about Kalispell. That's the behavioral piece in my mind. I mean, it's the piece that we're missing right now, and fortunately we have some terrific support from our hospital in helping put that together. But that's the piece that 90% of patients who are on a drug regimen that's probably not going to change substantially over time need. Because if you think for a moment about the last slide that Dr. Dahl, I hope I'm pronouncing the name correctly, showed us this morning, there's a challenge here to show that what we do in chronic pain management matters. And there's already a paper in a well-respected journal that Dr. Dahl showed us suggesting that the long-term use of opioids, for example, is not efficacious. In my mind, if I'm treating patients and I don't have a way of impacting all of the other things that go on in their life outside of their daily VAS rating, for that day, then I'm probably going to be hard-pressed to show efficacy. Everybody here in this room knows that opiates and neuropathics are profoundly effective for reducing nociception, but we also all know that all of these patients' lives have been impacted probably over a considerable period of time. So their spiritual life, their sexual life, their economic life, and those things do not reverse just because you drop their pain level from an 8 to a 5, which makes them happy in terms of their nociception, but doesn't change their life. So I think for me, that's where the behavioral piece comes in, and as Randy said, that behavioral piece could look like a lot of different things. It could be psychiatry, psychology, sociology. I think the more the better. But I think that's really where the money shot is for the future. And I think the challenge is upon us to demonstrate efficacy in what we do. So it's encouraging to see groups like Randy's involving research, and we're just starting to look at that piece as well.
Sounds to me like there's a fair amount of variation in the way these teams are put together from community to community and group to group. Also sounds to me like there are issues about lots of different specialists that are coming together to share their expertise, their refined area of expertise, and that there's communication issues, whether it's meetings or other tools used to collaborate. And so I'm going to ask some tough questions for you to address, because I think it implicates, the discussion on these points implicates several big issues that are discussed in healthcare policy right now, given the cost pressures that we're all facing in trying to figure out how to deliver health care to everybody in society so that we can afford it as a society. One thing that's discussed widely now is the need for more standard-based medicine, evidence-based medicine, more consistency in the way that we approach these kinds of problems from community to community. Another thing that is an issue that's widely discussed is the kind of fragmentation of healthcare delivery into subspecialties with more and more specialists that cost more and more rather than the older integrated approach of a more general practitioner providing this kind of care. And then finally, the issue of health information technology, which many people extol as a means of promoting this kind of collaboration and reducing the cost of it. So let's go into those areas just a little bit, and let me ask you, do we need better evidence-based standards, more standardization in the way we approach team management of pain?
You know, yes and no. I get a little bit frustrated when doctors say, well, we have to have everything be evidence-based, because those of us who've been doing medicine for a while, and particularly in pain management, recognize some of that there's an art of medicine too, and I think part of the issue around pain is that there is a certain art to it, and we don't have good data out there, and if we wait for all that good data, people are going to go untreated. I think what Randy was saying about pain being a public health issue and really tackling it that way, that we could save lots of money for the healthcare industry if we can intervene in pain earlier, get good post-op care, get good pain management initially, early on, educate people about what pain is really all about, and that I think the approach is to approach it from a public health standpoint, rather than, well, we're better in terms of evidence-based stuff out there, but if we wait for the gold standard, I'm not sure there really is one. And if you look at the equal analgesic tables, which says morphine equals this in terms of fentanyl, in terms of hydromorphone, that a lot of that was actually pulled out of a hat. And they're starting to look at that a little bit closer to see really what equal analgesic stuff really matters. But I think if we wait for evidence-based to get going, we're going to be behind the ball on that. So.
I think as a physician, there's three basic ways you make decisions. You either make them dogmatically, the way you were trained, you make them based on your own experience, or you make them based on new data. For me, the dogma came at some point from data. My experience comes from making decisions based on either dogma or data. So it all boils down to eventually, I think we've got to have a consistent approach. I do think there's an art to medicine. I don't think that we need to wait for the gold standard, but I think that we have to have evidence that what we're doing makes sense. So I think ultimately, yes, we have to move towards evidence-based medicine. And what we heard this morning is that there's not a lot of good hard evidence whether what we're doing in the long run makes a difference. So we're doing things on dogmatic decisions or our experience of what works, and neither one of those, I think, is clearly sufficient. So we have to have some evidence as to whether or not, if we're treating patients with anything, whether we inject them, whether we give them opiates, whether we treat them with behavioral medicine, we need to be able to look and say, this is best. It's the scientific method. I mean, we've adopted that everywhere else in our culture. So, yes, I would say we've got to.
I think the answer to the question is yes. However, my concern is just about common sense. I'd like to echo what Catherine said about, I can't foresee a day when the creative part or the art of medicine is somehow legislated. And I think the process of, for lack of better terms, because I don't know them, of legislative mandates lags so far behind the clinical experience that Randy alluded to, that you have in the day-to-day care of patients and the things that you learn on a day-to-day basis to become ineffective. That's my concern about that. My brief comment about common sense just has to do with what I probably should take back about the interventionalists. Those physicians are trapped to some extent by a reimbursement system that rewards them for doing things to patients, whereas actually taking care of the patient in a face-to-face encounter is not. So, so there has to be some common sense from the system side of things, and how we pay for services, how we look at that. And I think that in this particular area of pain management, that we wind up with a payment system where the tail's wagging the dog to some extent. And that's unfortunate because it eliminates or makes care difficult for probably 90% of our patients.
Are the literature and professional association standards moving providers more in the direction of more standardization?
I just wanted to comment about your first question real quickly. At first, I don't think anybody would argue that there's value in having knowledge, and I would certainly encourage ongoing research, and I know it will happen. I think that it would be helpful to me if there was better evidence base on which I can practice medicine. For a lot of reasons, it would make it better, first of all, but it also, I think, would help others who don't necessarily agree with the way that I practice medicine. As long as it's evidence-based, I think it would add validity to what I do, and a certain amount of what I do is just as Dr. Seacrest kind of suggested, that it's kind of our experience and what seems to work, and even though you can't necessarily definitively prove that opioids improve function, I can say that I have a fair number of people that tell me that my willingness to provide those medications to them have dramatically changed their lives. And I question how ultimately that evidence-based medicine is going to work, because we need better endpoints than I think what perhaps we're using now, because I think that maybe demonstrating improved function is too firm, or it may be an unreachable endpoint that we need to look to other things. And I'll leave that to people who are far brighter than I am to establish definitively what those will be. But I would certainly welcome some better kind of literature in order to present to people when they tell me that I'm making their patients addicted to narcotics or opioids. I don't prescribe narcotics. But there's the literature. No doubt there's an ongoing effort in order to provide better basis of information in order for us to practice from. So,
let me just ask you to address this HIT issue, and then we'll invite audience questions. It seems to me whether it's addressing the payment system or whether it's addressing the availability of data and evidence for practice standards, or whether it's collaboration with members of your team, that an integrated health information technology system would be beneficial. And I'd be interested in your comments about the extent to which HIT exists in your community, and whether you need more of it, and if so, how we get there.
At our hospital, we're still kind of dictating, and all of our records are kept in a file form that sits on the shelf. And the competing hospital in the community has gone to an electronic medical record and is using that very effectively to market their hospital. and the focus on trying to advance our ability to generate electronic records and share those is intense right now, because it's certainly recognized as a needed service in the hospital in order to provide better care, first of all, but also to present themselves in the eyes of the community as being progressive. So right now, I feel like we have a long ways to go where I work in that regard.
We're in the process of instituting electronic medical records. We're probably a year away from it. It's been an extraordinary process just to get everybody to agree to what system to use. And we now have, I think, about 100 of our community physicians who are all going to be on the same system, which is going to make a major difference just in terms of tracking medications and tracking problems, which will be fabulous, and also in terms of setting up standards. So I think that'll be a big help. But it's a huge financial investment. I mean, it is extraordinary how much this is going to cost us, and we've had to do separate fundraising just to be able to afford the cost of this. So while it's going to be great, it is not cheap, and it's going to take probably, I would imagine, at least 6 months for us to get good training so that we all know what we're doing. And then there's, of course, the docs who don't want to do it, but they kicking and screaming they will.
I'm probably the world's biggest computer geek, so the answer to that is probably yes. Two things that I would use as examples. One is we have an electronic prescribing system in the pain program, and both of the practitioners that manage medications in our clinic have said, after 1 year of using it, said we would never manage this amount of medications if we didn't have this system. So I think if I took it away from them, they would immediately leave. So it's so amazing, the database function of being able to bring up a patient's whole prescribing history, that you, especially with a team approach where you are not necessarily relying on your memory. So anybody may need to interact with that patient, and having that history there with every script written is pretty powerful business. It's very efficient, and from just the electronic prescribing piece, it makes a huge difference. The other piece that I would say is the PACS. If you want to take one function for any practice of medicine that uses x-rays like orthopedics or something, or pain medicine, having access to PACS and being able to literally access any x-ray a patient's had from Polson to Hamilton it reduces the visits to the patient. When I used to not be able to do that, I would have to send patients out and say, come back when you have your x-rays or when we have your x-rays. That sometimes went on for 2 visits before I could ever definitively deal and give that person what they needed. That has changed drastically just with PACS unit, just managing x-rays. X-rays are just another piece of data that we use. So you can look at that and say that's the same for EKGs, lab results, any of those things will behave almost in the same way. So yeah, I'm a big proponent of that. I think that it has to be balanced against privacy issues. I mean, I think one of the biggest issues that I'm concerned with is what can insurers do with that data if they get a hold of it. I don't want to see, if any of you have ever seen the sci-fi movie Gattaca, which is sort of a movie about what happens when you take this to logical extremes. When my life and everything that I do is based on my genetic profile, and my opportunities are based on my genetic profile, I'm not going to be real happy about that, because I'm not certain I've got a real good genetic profile. So, I mean, with those caveats, I would say it's absolutely a win.
Montana does have a law about that, and the federal and Congress just passed a law about it too. So, I think lawmakers are moving in the right direction. Steve, do you want to comment on this? And let me just also ask you to if you have any thoughts about what policymakers, if anything, ought to be doing to promote HIT and interweave these systems that are being built. As a policymaker, I'm particularly interested in that.
Just give us some money.
I agree with Randy that he's the world's biggest computer geek. And
You just got email last week.
Right, and I just got email last week. Precisely. You know, my personal story is identical to Randy's. I mean, I resisted, you know, prescription writing programs on the computer. Fell into the X-ray thing a little bit easier, and you know, the result is the same, though. They're phenomenal advances in our ability to care for patients more efficiently. And so it only makes sense that if you extend that to other areas of the patient medical record, it will follow. So I'm in agreement with that. Yeah, as Catherine said, give us money. I mean, I don't know how else to say it.
We could do the programming.
Well, I supported a bill in this session to appropriate $3 million to the HIT task force for the purpose of a pilot project that would, at least within one of the major communities in the state, begin to try to build a uniform platform. But unfortunately, like so many things in this session, it crashed and burned. We did get a resolution through, however, saying that we think it's a real nice thing, but you don't get any money. Okay, let's go to the audience. Yes.
I'm
Janice.
Janice Gomersall. I'm a family doctor down in Lowell, but I live in the Missoula community, so I really appreciate Dr. Seacrest's team. I use them significantly. And one of the things that I really appreciate is being able to call in as an outside practitioner and ask Leanne Bradley, the pharmacist, you know, I've got a patient who's having this problem. And I think that has been very, very helpful. So that's one of the things that with the breakout sessions I'll push. The other thing is, in my spare time, I'm the medical advisor for the Montana Medicaid program. And that program...
Can everybody hear Janice? Okay. All right. Dr. Roberts says...
In my spare time, I'm the medical advisor for the Montana Medicaid program. And as of March 1st, one of the diseases that they added to their disease management is chronic pain, which shows a lot of foresight that they actually recognize it as a disease. And through that program, we identify the patients, we teach them lifestyle changes, we get out to their providers and get education to the providers. There's a consistency in all the mailings, the phone calls, the community-based nurses who visit them. You know, and it really helps in terms of giving them many more modalities other than the opioids. And the other thing is we can reach out to the rural areas because we do a lot of telephonic medicine, and that way you can reach, when we were talking about some of the limitations in being able to do outreach, we really can do that with the program. Now, it's not a prescribing program, it's RNs who are managing it and the community-based nurses who do it, but we're there to support the providers. You know, what does the provider want to do? How can we help you do that? How can we help your patients to do that? And I think a lot of what Dr. Seacrest said early on in terms of doing a policy change, doing a system change, this is a system change, but it is also treating the individual patient. So it has the best of both worlds. We still have our barriers. I mean, we have to get people who want to see Medicaid patients. And that's not that easy. But at least the funding is there. This is a covered benefit. So the patients do get all of the resources that are available.
Comments about that? Yes, hand it back here. Yeah.
Here, I'll bring you this. It's like telephone.
Thank you. My name is Jan Yonner, and I'm a nurse at St. Peter's Hospital in Helena. And, you know, I know that we've discussed at least the connection between acute pain, undertreated acute pain that then evolves into a chronic pain condition. And, you know, I think one of the things that we haven't talked about is the situation at acute care hospitals as far as the amount of education that is not there, the systems that are not set up well for really truly effectively identifying pain, assessing pain, and then doing really good management. And I've had a couple little situations that have come to my attention lately that, you know, opportunities for education, but I guess I am wondering, I know that Benefice and both of the hospitals in Missoula have resources allocated from their hospital for their pain teams? Is there any place else in the state of Montana in their hospital? I think we're all mandated to have some kind of a pain team. Is anybody got any FTE other than those 3 hospitals? Okay, so I think that tells us something about somehow or another a committee of people that are already doing a jillion other things is supposed to really impact physician education, nursing education, and patient and family education, and maybe do a little bit of community education on the side. So, you know, part of the problem is, again, back to the resources, but at the bedside where, you know, most people that come to the hospital, I don't know whether it's accurate to say 80%, are dealing in some way with pain, or once they're there and they've had their surgery, they're going to have a pain experience. And we're not really addressing the problems in the acute care setting. And I know we've talked a lot about what's going on in the chronic, but we have to think about the whole picture in the state of Montana. So anyway, thank you.
Panel members, you want to comment on adequacy of continuing education for providers on pain management?
You know, our focus is acute pain management in the hospital. No, we don't have an FT dedicated to that. We do have some dedicated to palliative care, and that's how we're approaching it. And we're also trying to get pharmacy to get an FT, which would be great. But I am a little skeptical of CME for physicians and for practitioners. I think it only goes so far. What we've found is much more successful is when we're actually at the bedside with our palliative care team doing pain consults, and then that really has an impact. We can, you know, I can talk, we can give lots of talks, CME talks, but I've become a little jaded about how successful that is.
Yeah, I would agree. I think that at St. Pat's, we're still struggling with just whether to provide CME for anything, whether it's, I'm serious. I mean, because pain, you know, practitioners tend to go elsewhere to get their CME, and our just CME conferences are pretty poorly attended, if you, like Friday morning medical conference and that sort of thing. I wonder if it's not part of this whole initiative that Kristen's put together to try to create some help, some packages, so to speak, to both educate and then model programs to bring to some of the hospitals and allow people to take advantage of that. There's no sense in reinventing the wheel at every hospital. If we can coalesce some of that activity and bring it in as a package and just sort of say, if you're ready to create a pain initiative for acute pain care, for example, here's what has been put together for the state of Montana. Take it, start here, adjust it, adapt it to your own environment, and we've got people ready to come in and educate you when you're ready and make that resource available. I think that'd go a huge way towards really facilitating that process. So that's something that probably in the breakout sessions you ought to discuss, because that's one of the things we're trying to decide is what needs to be done.
I may be a bit of a cynic on this, but to echo what Randy said, I'm not sure that any of the data on CME per se, at least as applies to one of the more pathologic populations, which is, say, us physicians, has any impact on behavior, and really raises the question of its utility. And maybe, Catherine, something you said a few minutes ago is the key, is that education, maybe it's the way we educate, and don't shoot the messenger sort of thing. And so maybe education, particularly in the area of pain management, needs to be more along some type of experiential lines in order to make a difference.
Just wanted to comment, at St. Vincent's Healthcare, we have an advanced practice nurse that runs an acute pain service, and she does an outstanding job. Her name is Janine Brandt. She is very progressive in her thinking, and I believe would be a good resource for anyone who had questions about how that might be kind of organized in your own hospital, although I don't have permission from her to say that. I hope she doesn't mind if she starts getting calls from you all, but I've found her to be very willing at any time to talk, and I expect she'd be really happy to work with you all as well. As far as education is, CME education, we used to have a CME conference once a year, and if it was timed right, we had excellent attendance, and I have to say the conversation a lot of times I thought was very stimulating. Afterwards, I felt that there was a lot of interest, and I don't know how much what was learned there really changed practice. I think that partly people attend those because it's inexpensive and it's local, and so they don't have to travel outside of the area. As far as people who are interested in pain practice, just as Dr. Dahl mentioned earlier, there are conferences all over the country going on if you're willing to travel outside of the area. But of course, that's, if you're going to go to those conferences, you're going to have a special interest in pain medicine and probably practicing it. So those aren't the people we really need to be trying to modify their behavior. So,
Dr. Roberts.
I'm going to come up front because I can't do the twisting thing. I just wanted to say something as a family physician who's been in this state for 24 years practicing primary care. First of all, I'm very proud to be a member of the team at Northwest Spine and Pain. I had a revelation this weekend as it came into my mind that maybe we should change the name of our clinic and get the focus off of pain. And maybe that's something we'll talk about in the future, Steve. Maybe it should be Northwest Spine and Wellness or something. Just like our speaker earlier said, let's change the word chronic to persistent. And maybe let's get the word pain out of there, and maybe let's talk about wellness, because I think that's what family physicians do very well, is look at the scope, the broad scope of what is wellness. The best buy in medicine, the best bang for your buck is your primary care physician. I hope you all have one. So I want to give them kudos, and the state legislature needs to know the bulk of the work of medicine in this state is being done by our primary care providers, whether they're a physician, a nurse practitioner, or a PA. So my hat is off to them. I also want to give Steve kudos. Steve has my utmost admiration for being a pioneer in the field, and like he said, this clinic in Kalispell, that really he has single-handedly forged, and it takes a special physician who wants to sit there in the room with the patient who is absolutely suffering and spend time with them. And my eyes have been open since I've joined Northwest Spine and Pain. I came in November, and I'm really in awe of the patients that are there. I've learned so much, and I see tremendous suffering every day. We're seeing a lot of success, thank you to some of the pharmacologic agents that are out there now. So I just need to say a couple other things that I've taken notes for, because you guys have all stimulated this speech. So Steve, thank you for what you have done for our patients in the Valley. I was interested back in '87 in I was seeing this spectrum that I couldn't deny of headaches, muscle spasm, and insomnia, particularly in women in their 40s and 50s, and my curiosity was piqued, and I didn't know how to deal with it, but I was seeing it over and over again in my practice. And then in 1990, the rheumatologist finally came out with the myofascial diagnosis, fibromyalgia, the criteria, the diagnostic criteria. And I noticed in the speaker's slides this morning references to, arthritic conditions and cancer and everything, and spinal disease. But in a telling way, the myofascial pain patient was, I thought, left off that list. The invisible disease, we don't understand the cause yet. We have great treatments now for fibromyalgia, and that has become my specialty treatment area in the last 15 or so years. I myself was diagnosed with fibromyalgia in '94 after my 4th pregnancy, and in around 2002 got my rheumatoid arthritis diagnosis. And I'd like to have a show of hands. How many people in this room live with chronic pain daily? So fewer than I expected, because it should be 1/4 of you, according to the statistics this morning. But I sort of think that we're in this room, we're preaching to the choir, as has already been said. I mean, we already have an interest in chronic pain. I think there are physician barriers to the patients in our clinic as Steve and Mike have already said, the patients are referred way too late. They're already on their narcotics. They're already on, their road to dysfunction. I think that part of the barrier is allopathic medicine. We physicians are the barrier because we like quick diagnoses. We like a lab test that confirms the diagnosis. Blood pressure of 200 over 100. We like a blood sugar of 300 or a cholesterol of 250. It makes the path pretty clear. We don't like a patient that says, I'm miserable and can you help me, because that takes time, and a lot of physicians don't want to spend that time. Diagnoses like sleep apnea, restless leg, fibromyalgia, they go unnoticed. They are rampant. Every single chronic pain patient has at least one of those diagnoses, if not all three, in my experience. CNS plasticity gets into that. The CNS does change over time, and the purely mechanical back pain patient becomes the myofascial pain patient, and in my clinical experience in 10 or 15 years becomes the rheumatoid or lupus patient. I always see the fibromyalgia patient getting their primary diagnosis later of rheumatoid arthritis or lupus. Look for it, it's out there. Most of them have evidence in their hands, if you look at their hands, of those diseases. I would propose here that it's patient circumstance, their spirit is being slowly killed. They're being slowly strangled by the system. I think high-dose narcotics are the scarlet letter of 2007. For the patients, the white paper attests to their concerns for addiction and tolerance. Therapies are being withheld. The pharmaceutical industry, Avram, I love you, and Shane, I love you guys. The pharmaceutical industry, though, controls Western medicine in the US. And we have to be willing to look at other modalities, the naturopathic or the herbal or the, I'm wearing my electrode. I wish you all would go and put that alpha stim unit on while you're sitting here, because it'll help you get through the day. I do use this modality with my patients, and I actually own one of these machines at home. For provider, the scarlet letter is their time and their judgment. Providers are judging our patients. They're looking at Mr. Smith saying, you don't look like, you should be this sick, your spine doesn't look that bad on the MRI, therefore you can't have this much pain. And I would say that that is wrong. As far as the pain team, what does it look like? I'd say forget the degrees, folks. Let's forget the degree. Let's look at the heart. Let's look at whether the provider is interested in what they're doing, because I think that's what counts. And so OT, PT, massage, chiropractic, acupuncture, herbalists, I really think it's the provider's interest. And if you have an interested provider, that is what is going to help the patient get better. As far as education, do we teach our nurses and do we teach our physicians? I think it comes down again to a heart issue. Scripturally, Matthew says, out of the overflow of the heart, the mouth speaks. I think that's huge in pain. If the provider is not interested in pain, they're not going to do a very good job treating the patient. So I already said, let's get the word chronic out of there. Let's go with the word persistent. Let's maybe even get the word pain out of there, and let's focus on wellness. Northwest Spine and Pain will be going EMR in the next year. And we already, I agree with Steve and Mike's assessment, Randy's assessment. The EMR prescribing, the electronic prescribing is a huge godsend, having done pain management in the primary care setting with a written system for the last 20 years, and then just recently transitioning to this system at Northwest Spine and Pain. It is hugely more important, and we are taking a step with our ER to have them get access to our prescribing so that when the patient shows up in the ER, the physicians know exactly what they have been prescribed and when they last got their prescription. So it is a road, and we learn by experience, and that's my experience. Thank you.
Dr. Roberts, thank you very much for that addition. And I second your comments about the appreciation for providers who are dedicated to dealing with a very difficult issue. I remember 10 years ago, when I was practicing law, I had a client who was a woman who had fibromyalgia, and the ambiguity of the disease and the frustrations in treating the disease were obvious throughout the whole case. And right across the street, Western Montana Clinic, we had a deposition of a treating physician who was a wonderful lady, great doctor who I knew to be a caring doctor, but in the middle of the deposition she just sort of erupted and said, you know, I don't have time to have chronic pain. I'm too busy. And it was obvious that this was just you talk about the overflow of the heart, it was a frustration in just dealing with something that's so hard to get your arms around. And yet we all knew that this woman, you know, had some serious medical problems going on and needed to be addressed. So the physicians who and the other providers who dedicate themselves to this are doing yeoman's work. It's tough work. Other questions? We have about 5 to 7 minutes left. Yes. Linda.
When we went around and talked about the interdisciplinary team, you're going to guess I'm going to say, where was the nurse? But it raised an interesting issue in my mind because, you know, nurses are not doing treatments. What we're doing is the education and the coordination and the communication. Those really important factors are not reimbursed. And so it doesn't occur to people to talk about the nurse as a member of the team. And I'm just curious how can we address that? Because we all need nurses, I think, as well as doctors.
Panel members?
I couldn't do what I do without the nurse that I work with, who's sitting right back there, Deanna Brame. She is key to everything I do. So it was a lack of. It was just a lack. Sorry, right, sloppy. But the nursing team is very much a part of our pain committee. And, half of what we do is working with nurses around educating them so that they feel empowered to come forward to the physicians and say, this person is in pain, what are you going to do about it? So, the nurses are just key to everything I do.
Yeah, I'd agree. They're the glue that holds the whole ship together. Enough said. I don't know how to fix the focus because I think that the nurses are always those people that are holding the ship together, but they're just like the air you breathe.
Absolutely. It just happens in this vacuum. Because we don't recognize the importance and we don't pay for it. We don't factor that cost of that really important coordination that I think the nurse provides. Plus sort of fitting, like I tell my students, what a nurse does is help a person fit this in their 24-hour day. We're sort of the formal family, and we teach them the self-care, and then they can take over for themselves, and we're sort of coaching them in that process, working ourselves out of a job. That's what we want to do. And I don't think our healthcare system even figures that into the cost of healthcare. And it's so important.
I'm feeling like Phil Donahue here. You want to comment, Dr. Schumacher, on the issue of reimbursement?
Well, I have to apologize to all the nurses in the audience because I didn't include that in physiatric practice, at least in the inpatient rehab setting. The nurse provides some of the best information when we have our conferences. They spend more time with the patients than I do. Patients oftentimes will say things to nurses that they'll never say to me, and it's incredibly helpful to have the nurses involved. At St. Vincent's, we've developed some method to monitor productivity of different providers. It doesn't necessarily lead to better reimbursement, but it leads to recognition by the hospital of services provided by nurses. And we have a check-in form in which nurses, when they bring the patient in, comments on different aspects of the interaction, reviewing the medications, talking to them about other problems that they've had in their life. And a certain amount of time is assigned to that. Clearly, nurses, the salaries that are assigned to everyone that works in healthcare equate to a significant amount of money, and unfortunately there's no way to really designate how much, that I'm aware of, how much of any single resource is devoted to a single patient, and it would be helpful if there was some way to designate that. It would, especially if it improve our bottom line.
Doctor, thank you. I'm sorry we're out of time. Can we do one more quick question? Okay. Please, go ahead. One more quick.
My name's Mary Beebe, and I'm from Livingston, but I work at the mental health center. I don't have a license of any kind. I'm a caseworker, and I have been for about 7 years. And one of the things that we just talked about was coordination and how, education, everything. But I find that, like so many things, mental health and physical health get separated. And what I have found is that so many people that I work with as their case manager end up primarily with, it comes out, it isn't the presenting problem at the mental health center, but pain is the issue, is such a primary issue in their lives in terms of their functionality and their ability to live a fulfilling life. And one of the things I realized when we do intakes, when we do treatment plans, we always ask people about substance abuse. We never ask them about pain specifically. And that seems a real lacking to me, because it seems that the more I get to know people, the more I realize how much pain is part of the whole syndrome, whatever it is. And that many times I think it ends up ending up being the primary issue. And that also what has amazed me is how long it takes a person to reveal that. They're getting therapy, they're getting psychotropic medications, they're going to the doctor for their routine medical care, but they haven't told anybody that they have chronic pain. And they're so afraid of that. And I think they're afraid of all of, there's a whole stigma that we've talked about. But luckily, right now, working with community health partners, I've been able to refer people to someone who listens to them about their pain and has actually started to, and has helped people and relieved their suffering. So I think that somewhere in here, the collaboration between the mental health centers and the rest of the medical community, not just around substance abuse and diabetes and the other things that seem to co-occur, but really to focus on that as a primary issue, and to get to that before people have been in the mental health system and taking Seroquel and everything else for 2 or 3 years before they finally say, I never sleep because I have chronic pain. And just one other second issue was, in my job, I do a lot of being with people. We go to the pharmacy, I go with them to the pharmacy, to the doctor, I'm in their homes. And one of the things that has come up more than once is the pharmacist becoming very suspicious and intervening and questioning, sort of challenging any physician's use of opioids in particular. And so I guess that's the other piece, the pharmacies themselves, maybe not just the pharmacologists, but the people who actually are standing behind that counter, getting some kind of education and linkage and background, because the trauma of having of a patient who has to deal with chronic pain anyway and has finally had the courage to go to the doctor, to go there and be questioned about their abuse of their pain meds because they're a day early to pick up their prescription is, it's just, the suffering is intense mentally for people, and the stigma is immense, and the kind of damage that can be done by a very careless comment. So anyway, those are 2 things.
Any quick comments on dealing with the stigma and destigmatizing and getting the early treatment going?
How much time do you have? It's huge, and it just is. It's huge, and it's an education issue, and it's everything that we've been talking about. So